Welcome to the deep dive. We've got a really challenging set of sources this time, all focused on probably the most common electrolyte issue out there, hyponatremia.
Right, where the serum sodium dips below about 134.
Exactly. And our mission today is to navigate the real tricky part, that hypotonic hyponatremia where the body isn't getting rid of water properly. You see that with a high urine osmolality, over 100.
That high UOSM tells you ADH, the antidiuretic hormone, is active when it probably shouldn't be. But the big question the sources wrestle with is figuring out the patient's actual volume status, their effective circulating volume, or ECV.
And the usual first test, urinary sodium, often lands right in that frustrating middle ground.
That's the problem. That UNA between, say, 20 and 40 millimole, it's a real gray zone. It just doesn't reliably tell you if someone is hypovolemic, volume down, or euvolemic.
So why is it so deceiving? What throws it off?
Well, lots of things, unfortunately. Take SIADH syndrome of inappropriate ADH, that's usually euvolemic, maybe even slightly volume extended. But if that patient happens to eat very little salt, their kidneys will desperately hang on to sodium. So the UNAT looks low, maybe less than 20, even though they aren't truly volume depleted.
Ah, I see. And the opposite can happen too.
Definitely. Think about someone who is genuinely hypovolemic, but they're taking a thiazide diuretic.
Right.
The diuretic makes them waste sodium in the urine. So their UNA might look high, maybe over 40, completely hiding the fact that they're actually volume down. Those static numbers can really lead you astray.
And getting this wrong is, well, it's bad. If you think someone has SIADH, but they actually have, say, adrenal insufficiency, which is hypovolemic, and you fluid restrict them.
It's catastrophic.
Yeah.
Absolutely catastrophic. You worsen their volume depletion severely. So ruling out those endocrine mimics adrenal insufficiency, severe hypothyroidism. That's step one. It's mandatory.
Okay, so if UNA isn't reliable for volume status, where do the sources point us next? What's a better marker?
The sources suggest looking at serum uric acid. It's a more objective surrogate for ECV in this context.
How'd that work?
Well, in SIADH, remember there's often mild volume expansion. This triggers the body to excrete a bit more sodium and along with it more urate.
So the uric acid level drops.
Exactly. You often see a low serum uric acid, maybe less than 0.24 millimol.
Yeah.
That's pretty characteristic of SIADH.
Okay, that helps distinguish SIADH. But what about conditions where someone is volume depleted and losing salt, like cerebral salt wasting, CSW?
Good question. That's where we need to look dynamically, usually at the fractional excretion of uric acid, the FeU rate.
FeU rate?
Yeah. Now, both SIADH and CSW might start with a high FU rate, say over 11%. They're both getting rid of extra urate initially.
So how does that help differentiate?
The key is what happens after you start correcting things, usually with saline. In SIADH, as the volume status kind of normalizes, that high urate excretion stops. The FeU rate goes back to normal.
Okay.
But in CSW, the kidney is fundamentally wired to waste salt. So even after you give volume, the FeU rate stays high. It persists. That tells you it's pathological salt loss, not just a response to volume like in SIADH.
That makes sense. A persistent high FeU rate points toward a CSW. Now, what about that patient on diuretics where all the sodium measurements are unreliable? Is there anything left?
Yes, thankfully. We turn to the fractional excretion of urea, or FE-urea.
FE-urea.
Right. Even when diuretics are making the kidney waste sodium in true prerenal volume depletion, the kidney still tries hard to reabsorb urea to conserve water.
Oh, okay.
So if the FE-urea is low, generally less than 35%, that's a pretty sensitive sign that the patient is indeed hypovolemic, despite what the diuretic is doing to their sodium excretion.
Got it. So FE-urea less than 35% suggests hypovolemia, even with diuretics on board. But what if, after all these static tests, UNA, uric acid, FE-urea, you're still not sure?
Then you move to the gold standard, the dynamic test, the isotonic saline infusion challenge.
Giving 0.9% saline.
Exactly. You carefully infuse isotonic saline and watch what happens to the serum sodium. This forces the body to reveal its true ADH physiology.
So how do the responses differ? Let's take the hypovolemic patient first, like someone with adrenal insufficiency.
Okay, in that case, they need the salt and water. Their body retains the infused saline, their effective volume improves, and this appropriately suppresses ADH release.
Meaning their kidneys start excreting water properly again.
Correct. And you see a significant rise in their serum sodium, usually an increase of more than 5 millimol. That confirms they were volume depleted.
Okay, clear correction. Now, the counterintuitive one, SIADH. What happens there?
This is the key diagnostic part. In SIADH, the ADH release isn't driven by volume or osmolality. It's inappropriate. So when you infuse saline,
The ADH doesn't turn off.
It doesn't. The kidneys, under the influence of ADH, hold on to the water from the saline infusion, but they readily excrete the salt.
So you're giving salt water, but they keep the water and pee out the salt.
Pretty much. The net effect is that the serum sodium barely increases, often less than 5 millimol. Sometimes it might even drop slightly, paradoxically. This failure to correct confirms the ADH is inappropriately active.
Wow, okay. That's a stark difference in response. And that leads right into treating SIADH, which isn't always straightforward either.
No, it isn't. Fluid restriction is usually the first step.
Yeah.
But sometimes it's destined to fail. There's a useful rule of thumb based on urine electrolytes.
Which is?
If you measure the urine sodium and potassium and add them together, if that sum, UNAIR plus UK, is greater than the patient's serum sodium level,
Okay.
that tells you the kidney is excreting urine that's more concentrated in electrolytes than the blood itself. In that situation, just restricting water won't work. In fact, it could make the hyponatremia worse because you're losing electrolytes in a concentrated urine without enough free water intake.
So in those cases, restriction isn't enough.
Correct. You actually need to increase the solute load, give more salt, maybe urea, or increase protein intake to help the kidneys excrete more free water. It's about the balance of solute and water excretion.
So putting it all together for you, the listener, the big takeaway seems to be moving past just looking at that often misleading urinary sodium in the gray zone.
Absolutely. It's about using objective markers like serum uric acid and maybe Fe urea to get a better handle on volume status, and then, if needed, using the dynamic saline challenge to really confirm the underlying physiology, whether ADH is suppressible or not.
It requires a systematic approach, really.
Definitely. And that brings us to a final thought for you to consider. We know the most common triggers for SIADH are actually medications. Things like SSRIs, certain seizure meds like carbamazepine, even some opioids.
Right.
So when you're faced with one of these ambiguous hyponatremia cases, how much weight should you give to combing through that medication list first before jumping into complex biochemical markers or the saline challenge? Could a careful medication review sometimes shortcut the whole diagnostic process? Something to think about.